if you take a little pill every morning for your blood pressure. Lisinopril, losartan, amlodipine, hydrochlorothiazide, or one like them. How confident are you that you actually understand what it's doing inside you, once it's not just a number on the label anymore? Most people pause at that question. And that's not a knock on you. It's a knock on the system. You get handed a prescription in the last 90 seconds of a 15-minute visit, and the conversation is almost always about the number on the cuff, not about the 4 very different jobs these pills are actually doing inside your body. Consider a man in his early 70s. Call him Walter. Walter had been on the same blood pressure pill for 6 years. No complaints, pressure well controlled, doctor happy. Then his ankles started swelling. Not painful, just puffy, every evening, tight against his socks. He assumed it was age. He assumed it was salt. He assumed it was just one of those things that happens after 70. It wasn't age. It was the medication, doing exactly what it's designed to do, in a way nobody had ever explained to him. A quick note before we go further. This channel is for general education, not medical advice, and I'm not your doctor. Nothing here is a diagnosis or a prescription. Always talk with your own doctor or pharmacist before changing anything about your medication, diet, or treatment. What I can do is explain the why, the mechanism behind the 4 most commonly prescribed blood pressure medications in this country, so that when something changes in your body, you know whether it's nothing, something worth mentioning, or something worth calling about tonight. Here's what we're covering: the 4 major families of blood pressure medication, what each one is actually doing to your arteries, your kidneys, and your electrolytes. And for each one, the specific warning sign your doctor may not have had time to mention. Stay with me through the third one, especially. It's the one tied to a mineral imbalance that can sneak up on you even when your pressure reading looks perfect. Here's the first thing almost no one explains. These are not 4 versions of the same drug. They are 4 completely different strategies for solving the same problem. And that matters, because each strategy comes with its own specific thing to watch for. Think of your blood pressure as water pressure in a home's plumbing system. There are only so many ways to bring high pressure down. You can widen the pipes. You can drain off some of the water. You can slow the pump. Each of the 4 drug families we're covering today does one of these, and only one. Lisinopril belongs to a family called ACE inhibitors. Picture a chemical signal in your blood called angiotensin II. It's a constrictor, a signal that tells your blood vessels to squeeze tighter and narrower. Lisinopril blocks the enzyme that manufactures that signal in the first place. Fewer constrictor signals, wider pipes, lower pressure. It's an elegant approach, and it also happens to protect the kidneys, which is why it's so often the first choice for people with diabetes. Losartan belongs to a related but distinct family called ARBs, angiotensin receptor blockers. Same villain, different tactic. Instead of stopping the constrictor signal from being made, losartan blocks the receptor, the docking site, where that signal would normally attach and squeeze the vessel. Same end result, wider pipes, but a different mechanism, which is exactly why losartan exists as an alternative for people whose bodies don't tolerate ACE inhibitors well. Amlodipine takes an entirely different approach. It's a calcium channel blocker. Your blood vessel walls contain smooth muscle, and that muscle needs calcium to contract, the same way your bicep needs calcium signaling to flex. Amlodipine partially blocks calcium from entering those muscle cells. Less calcium in, less squeeze, wider pipes. But through the muscle itself, not through a chemical messenger. And hydrochlorothiazide, often just called HCTZ, doesn't touch the pipes at all. It works on the water. It's a diuretic. It tells your kidneys to release more sodium, and water follows sodium out with it. Less fluid volume in the system, lower pressure. The same reason letting some water out of an overfull garden hose drops the pressure at the nozzle. Four completely different strategies, four completely different worth watching for lists. Let's walk through each one. Here's the scenario. Someone starts lisinopril in a few weeks, sometimes even months. Later, they develop a dry, tickly, persistent cough. No fever, no mucus, nothing that responds to cold medicine. It just sits there, day after day, worst at night, when they lie down. The mechanism. Remember, ACE inhibitors block the enzyme that makes the constrictor signal. That same enzyme also happens to break down a different substance in your lungs called bradykinin. When you block the enzyme, bradykinin builds up, and bradykinin irritates the lining of your airway. It's a known, well-documented side effect of this entire drug class. Not a coincidence, not a cold you can't shake. Consider a woman in her late 60s. Call her Evelyn, who spent nearly 2 months buying cough drops and blaming allergies before mentioning it at a checkup. The moment she said, "Since I started that new pill," her doctor recognized it immediately. The line between nuisance and emergency. A dry, chronic cough on lisinopril is a nuisance. Annoying, but not dangerous, and it usually resolves within days of stopping the drug under a doctor's guidance. But there is a related reaction on this same drug class that is a true emergency. Sudden swelling of the lips, tongue, throat, or face. Something called angioedema. If that happens, that is not a mention it at your next visit situation. That is a call emergency services now situation, because it can affect breathing. The safe action. If you develop a persistent dry cough on lisinopril or any ACE inhibitor, don't stop the pill on your own. Call your doctor's office and describe it. There are alternatives, including losartan, which we just covered, that typically don't cause this particular side effect because they work at a different point in the pathway. So that's lisinopril's signature warning, the cough that isn't a cold. Now let's talk about what losartan asks you to watch instead. Because switching away from the cough doesn't mean switching away from every consideration. Here's the scenario. Someone is doing everything right. They've cut back on salt exactly like their doctor asked. And to make food taste better, they've switched to a salt substitute or a light salt blend from the grocery store. A few weeks in, they start feeling unusually tired. Maybe some heart palpitations, a strange weakness in the legs. The mechanism. Most salt substitutes don't replace sodium with nothing. They replace it with potassium chloride, because potassium tastes similar to salt on the tongue. That's normally fine, but losartan and the whole ARB family, along with ACE inhibitors like lisinopril, work in a pathway that naturally causes your body to retain slightly more potassium as part of how they protect your kidneys. Add a potassium-rich salt substitute on top of that, and for some people, especially those with reduced kidney function, potassium can climb higher than it should. Think of potassium like the electrical wiring for your heartbeat. Too little, and the signal misfires one way. Too much, and it misfires another way. And either direction can affect your heart's rhythm. Consider a man in his 70s. Call him Robert, who felt off for about a week, chalked it up to the heat, and mentioned it almost as an afterthought at a routine blood draw. His potassium came back elevated. A simple adjustment, and it resolved. The line between nuisance and emergency. Mild fatigue is worth a phone call. Heart palpitations, muscle weakness that's getting worse, or irregular heartbeat is worth calling that same day. High potassium can, in rare but serious cases, affect heart rhythm significantly. The safe action. If you're on losartan, lisinopril, or a similar medication, ask your doctor or pharmacist specifically whether a salt substitute is safe for you before you start using one. And if you're already using one, mention it at your next visit or call sooner if any of those symptoms show up. This is exactly the kind of interaction that's easy to miss because both things, the pill and the salt substitute, seem healthy on their own. This one brings us back to Walter from the very beginning. Swollen ankles, worse by evening, better by morning after a night with his feet up. The mechanism. Remember, amlodipine relaxes the smooth muscle in your blood vessel walls by blocking calcium. It does this more strongly in the small arteries feeding your legs than in the small veins draining them. That imbalance, more blood flowing in, not quite as much extra capacity flowing back out, means a bit of fluid seeps into the surrounding tissue. It's not your heart failing, it's not your kidneys failing, it's simple, local plumbing physics from the way the drug works. Think of it like a garden hose, left slightly more open at one end than the other. A small amount of water is always going to pool near the low point. The line between nuisance and emergency, mild ankle swelling on amlodipine, is extremely common. In some studies, it affects roughly 1 in 10 to 1 in 3 people on the drug, more often at higher doses, more often in women. It is, on its own, a nuisance, not a danger. It's worth mentioning at your next appointment, especially so your doctor can rule out other causes. But swelling that comes on suddenly, is only on one leg, is painful, or is accompanied by shortness of breath, is a different story entirely. That pattern can point to a blood clot, or a heart or kidney issue, and that is worth calling about the same day, not waiting for your next scheduled visit. The safe action, elevating your feet in the evening, and mentioning consistent swelling to your doctor, is reasonable. Some people do well on a lower dose, or a combination approach instead. But don't stop amlodipine on your own to fix the swelling. Blood pressure that swings back up brings its own real risks. This is the one I asked you to stay for, because it's the one that's easiest to misread as just getting older. The scenario, someone on hydrochlorothiazide starts feeling more fatigued than usual, a little foggy, maybe some muscle cramps, maybe just generally not themselves. It creeps in slowly, over months, so it's easy to attribute to age, to weather, to a bad week. The mechanism. Remember, HCTZ works by telling your kidneys to release more sodium, and water follows the sodium out. But your kidneys don't release sodium in isolation. Potassium and magnesium tend to go out along with it. Over time, especially without regular blood tests to catch it early, this can add up to genuinely low potassium and low magnesium. And both of those minerals are essential for normal muscle function, normal energy, and a normal heartbeat. Think of your cells like a factory that needs a steady supply of 2 specific raw materials to run its machinery. HCTZ, over time, can quietly drain the warehouse of both. Consider a woman in her mid-70s. Call her Dorothy, who'd been on hydrochlorothiazide for years, without a single blood test to check her electrolytes, because nobody had flagged that it was due. Her fatigue and leg cramps had been quietly written off as just getting older for the better part of a year before a routine panel caught it. The line between nuisance and emergency, gradual fatigue and mild cramping, is a mention it soon issue, and it's exactly why regular blood work matters on this medication. But severe muscle weakness, an irregular or racing heartbeat, or confusion is a call your doctor today, possibly emergency room situation. Because very low potassium or magnesium can affect the heart's rhythm significantly. The safe action. If you're on hydrochlorothiazide long-term, ask whether it's time for a routine blood panel. Most guidelines recommend checking electrolytes periodically on this medication, particularly after starting it or changing the dose. This isn't a reason to be alarmed. It's a reason to make sure the monitoring that's supposed to happen is actually happening. Let's put the 4 nuisance versus emergency lines together in one place, because this is the part worth remembering, even if you forget everything else. On lisinopril, a dry cough is a nuisance. Sudden swelling of your face, lips, tongue, or throat is an emergency. Call 911. On losartan, mild fatigue is worth a call. Heart palpitations or worsening muscle weakness, especially if you're also using a salt substitute, is worth calling the same day. On amlodipine, mild, gradual ankle swelling is a nuisance to mention at your next visit. Sudden, one-sided, or painful swelling with shortness of breath is same day, possibly emergency room territory. on hydrochlorothiazide. Gradual fatigue and cramping means it's time for a blood test. Severe weakness, an irregular heartbeat, or confusion means call today. And the doctrine that sits underneath all four of these every single time. Never stop or change a blood pressure medication on your own. Even if you think you've identified a side effect, blood pressure that rebounds suddenly carries its own real risk. A stroke or a heart attack doesn't care why the medication stopped. The safe path is always the same. Notice the pattern, describe it clearly to your doctor or pharmacist, and let them make the adjustment. So here's the recap. These four medications aren't four versions of one thing. They're four different strategies for the same goal, and each one comes with its own specific, well-documented thing worth watching for. Lisinopril and the cough, losartan and the salt substitute potassium interaction, amlodipine and the ankle swelling, hydrochlorothiazide and the slow mineral drain that gets mistaken for aging. None of these are reasons to panic. All of them are reasons to pay attention and to have a more specific conversation at your next appointment than is my number good. If this helped make sense of what's actually happening in your body, type the number 4 in the comments. One for each medication we covered. It helps this reach more seniors who are having the exact same conversation you might be having with yourself right now. And before you go, tell me which of these four you or someone you love is currently taking. Your answer might be exactly what helps the next person reading these comments feel less alone in it. There's one more piece of this puzzle we haven't touched today. The time of day you actually take these pills can change how well they work and how you feel on them. That's the video I want you to watch next. The most dangerous time to take your blood pressure medication. Because timing turns out to matter almost as much as the medication itself.